Bismillahirrahmanirrahim. Assalamualaikum and a very good evening to all my posting mates as well as Dr. Chan, as our supervisor for the second teaching seminar. I am Nashahira binti Azmi. So our topic for today's teaching seminar is entitled regarding puberty. So there is a four presenter for today. Me, Shahira, Aina Siddiq, Arfan Nira, as well as Nadia. So first, as for my part, I will talk about puberty developmental and staging. Next slide. Next slide. So this is the outline. Internet slow ke? Baik. Can you hear me?
Yes, we can hear you.
So this is the outline. So we'll talk about definitions, physiological of puberty, what kind of physical changes that happen, the sequencing and staging, as well as references lah. So for my references, I'll take it from Sunflower, Pitts Protocol, Nelson, and Up to Date. So next, what is puberty? Puberty, if you take a look at Up to Date, it's stated that puberty is the general term for the transition from the sexual immaturity to a sexual maturity. Technically and approximately, female will have their puberty at the age of 10 to 14 years old, whereas male will have their puberty at the age of 12 to 16. What kind of physiological events that happen during puberty? There is a four most commonly that will happen by everyone. First is gonadaki. Gonadaki is actually an activation of the gonads by pituitary hormones. We'll take a look after this. I just give a brief what is that. Adrenarche is the increase in productions of androgens by the adrenal cortex itself. Telarche is the breast tissue development due to the primary actions of estradiol. And last is puberty. Puberty is the development style of pubic hair. So next slide. So we'll talk about physiological of puberty. So first, next. So gonadaki. What is a gonadaki? Gonadaki is actually, it is driven by an increase in a pulsatile secretions of gonadotropin releasing hormone from the hypothalamus. So when someone becomes increasing in their age, there is a secretions of G and RH at the hypothalamus that is secreted in a pulsatile manner. And what will happen is that it will increase the frequency and the amplitude of the productions of luteinizing hormone and follicular stimulating hormones at the pituitary gland. So what will happen is that it will be responsible for the enlargement, maturations, as well as secretions of the sex hormone. If LH hormone is from the Tika cells of the lady, so it will help in the testosterone, whereas FSH is ovary, so we aid in the production of estrogen. If you didn't understand anything, just stop me out. So secondly is adrenarche. Aina tekan je semua untuk adrenarche. Another illustration. Next picture. Another one. Okay, dah stop. So for adrenarche, adrenarche is the increase in androgen secretions by the adrenal cortex. So we take a look first is what is adrenal. So inside the component of adrenal, recap back, there's a two things, cortex and medulla. So as been taught by our doctors, at the cortex, we remember the mnemonic of GFR, which is glomerulosa, fasciculata, as well as reticularis at the cortex. So glomerulosa is help in the production of aldosterone because it releases the hormone of mineralocorticoids, whereas fasciculata is glucocorticoids for the cortisol. And then zona reticularis, this is the one that promotes for androgen, stimulate masculinization, such as DHEAS. And then another one is adrenal medulla. So when we take a look at the next illustration, you can take a look at the newborn at 1 year of age, 2 years of age, and at the age of 6 to 15 years old. You can see that from that thing at the fetal zone, there is no reticularis. And then we can start to see that there is a regeneration of zona reticularis at the age of 6 to 15 years old, which means at this age, first what will happen is that there's a regeneration of zona reticularis, and secondly, there's a production of androgen, in which at the same time we can notice that there's a growth of pubic and axillary hair, maturations of upper sweats, gland, as well as acne. So next slide. So Okay, kita Aina. So for tilaki, for the tilaki first, there's an increase in estrogen, which is in increase in estrogen, they will aid in the breast development lah. Technically, we can see that at the age of 10 years old, but this is depending on certain races. There is a lot of things etiology can differentiate lah. Second is puberty. Puberty is an increase in androgen that will eventually increase the pubic and axillary hair development. So when we talk about menarche happen when there is an increase in estrogen. And if you take a look either at the Sunflower, Nelson, or Up to Date, they say that roughly the first menses approximately happen at the age of 12 years old. And it is typically happen 2.5 years after tilaki. And it is said to be concerning if it does not occur by the age of 15 or 3 years after tilaki. So next picture. Okay, this is what puberty done lah. So by the GnRH, it will have the luteinizing hormone, FSH, and ACTH. So for the luteinizing hormone, testis, testosterone, gorodaki, FSH, ovary, estradiol, it will aid for the tilaki and menarche, and for adrenal, DHEAS lah. I'm not sure the full name, how to pronounce it is so long. So it aids in the adrenal androgens, adrenarche, and for pubic hair. So for next slide. We will take a look at the sequences, physical changes, and staging of the puberty development. So next slide. Okay, I have inserted like a couple of diagrams. So this is the first thing. So we take a look at in a female pubertal maturation. First thing that we have the tilaki, the breast development tissue, usually at the age of 10 to 11 years old. And there is a puberty at 6 to 12 months later. From what I read in the up to date, they said that 85% of the normal female that will have their tilaki first instead of puberty. But some of the female that will have a 50% of having puberty first, which is eventually will increase 3 times fold of having maternal preeclampsia at the later age lah, if the patient is still conceiving. So first we have tilaki and then puberty, and then we take a look at the patient. We have the menarche 2 to 2.5 years after the onset of puberty, and the growth spurt is earlier. I'm sorry. Growth spurt is earlier in the stage of puberty, average at the 12.1 years. The growth spurt is what differentiates between the male and female, because like as a female, we technically have a 2 years earlier of having a puberty stage compared to the male. So when we are having our menses, the first menses, after that we just completing the growth spurt. Macam tu lah. Technically, what does it want to say that if a male after having the puberty, they have another extra 2 years to start first. So that's the reason why they are getting more taller than us lah. So then menarche and then others. So next picture. To make it more understand. So the first diagram is what I get from the up to date, though it doesn't have that kind of relations because they put that black and white female, that's not for Asian. But technically you can see that first there is an initial breast development, then the staging lah, and then the heart velocity at 8 centimeter per year. And we can take a look that technically usually patients or female, they will have their first menarche at the range of 12 to 13 years, and then the completion of puberty by the age of 13 to 14 years. But take a look at the second picture at timing of the puberty. This one is I get from the Sunflower. At the Sunflower, they said that height growth spurts usually occur after 12 years old, and then the age of menarche is 12.25 to 12.5 years technically, and the breast stage. Completions of the breast stage, you can see at the age of 11 up until at the age of 15 lah, as well as puberty. To be honest, I'm not sure about what is the second, third, and fourth of the shape, but I think it is depending on the Taylor staging too. But maybe after this, we can ask better with Dr. Chen. So next slide. So what are the changes in a female that we can notice? Is that first, the vagina. The vagina itself, it becomes thicker and duller pink in color. Secondly, there we have the uterus, ovaries, follicle in the ovaries are increased in the size. The patient will have, the female, we will have menstrual infertility, and there is changes in the body shape and fat distributions, which is there is a pelvis and hip becoming widened, more fat distributed to the breast, hip, buttocks, thigh, upper arm, and pubis. Noted that in female, it is a differences in the races itself. For example, if someone have an Hispanic ethnicity from the Nelson, they have the tendency to achieve their menarche a bit earlier compared to the others and develop a bit a bit faster secondary sexual characteristic first, and second, they also said that someone who is obese at their childhood have their indication to have early menarche compared to the others. However, there is no certain explanation to that. And then thirdly, they also stated that if someone who is like athletic, I'm not sure about the other sentence, but I remember the word athletic. They also have the tendency to have kind of a delayed menses lah. So for the next slide. So changes happen during puberty lah. So as a female, we will grow taller, the breast will grow, the hair grows at the armpit, at the legs, between your legs, period begins, armpit sweats, and we may get pimples lah due to adenaki. So next slide. So tender staging for breast and pubic development. Tender staging is invented by Marshall Santana. So when we talk about breast development, there is a 5 stages as well as the pubic hair growth. I'm not sure if I have to explain one by one, but this is a common thing being asked in the MCQ. So what we can say that as stage 1, briefly, no breast development. Stage 2, there's a breast bud. Stage 3, further enlargement of the breast and areola without separations of the contour. But stage 4, there is a separation, nipples and areola projected to form a second mount above the level of the breast. And then the final is the stage 5. It is in a maturation stage, which is there is a projections of the nipple only. That's for the breast. So secondly, we take a look at the pubic hair growth lah. So for pubic hair growth, first stage, there is a fine, very light hair in the pubic area. Stage 2, sparse growth of the longer, pigmented, and then thirdly, darker and coarser, and 4, more like an adult, but it doesn't widespread. For stage 5, the hair is now like an adult pubic hair in both type and quantity, distributed in a classic triangle pattern, and has spread to a nearby thigh area. It is resembled to the male figures after this. So first, this is a sequence of male pubertal maturation. So birth of testes and thinning of scrotum happening at the age of 11 to 12 years old. And then there's a puberty and axillary hair growth. Growth state, it is happen later at the stage of puberty. Technically, they happen at the age of 14.1 years old, and they happen at the greater velocity in compared to the female. And there's others. So on the next slide. So from the up-to-date, I think we can appreciate better about the timing of puberty in males. So first, take a look at the age of 11 to 12 years old. We have an increase in the testicular volume, and then at the blue dots, pubic hair at stage 2 happen. And then take a look at the peak height velocity. It's a more compared to a female. Just now if we recap for the female, it's like 8, and now at the male, it's like 9 centimeter per year. And then there we have their gross birth, and then at the age of 14 years old, then we have their sperm in the urine lah, first akid balik, and then the completions of puberty at the stage 5, at the age between 15 to 16 years old. So if you take a look at the next blue figures from the sunflower, they said that the height growth of sperm is 14 years old lah. So from this stage, we can take a look at there is a testicular volume which is completed at the age of 12 to 16, and then the pubic hair stage, Okay. So next slide, the other changes that happen in the male are first, body and facial hair lah. Technically, the men tended to be more hairy than the female with the full of masculinizations. There's a voice changes at the same time of the growth of penis. Their voice becoming deeper, and there's a change in musculatures and body shape, which is they have the heavier bones, nearly twice skeletal muscle. The muscle developed mainly during the later stage of puberty. Technically, in male and female, the differences is that as a female, as we grow, as we age elder, our BMI increasing more due to our fat depositions. But as in male, there doesn't have a lot amount of fat because some of them are developing into a lean amount of mass muscle. So they also have a body odor, sweat gland, sebaceous gland, and acne about the same time when there is a facial and axillary hair growth. So next slide, Anna. So in male, what happened? Voice deepen, armpit sweat. Same thing happened as a female, but yeah, it's just a different in the private parts lah. Penis and testicle getting bigger. So next slide, Anna. So when we talk about a tenure staging, when we talk about tenure staging of extragenitalia, so first stage 1, the testis, penis, and scrotum of a childhood size. But stage 2, there's an enlargement of scrotum, but the penis doesn't enlarge. The skin, scrotum skin is reddened. And stage 3, there is a further growth of the testis and the scrotum and enlargement of penis, mainly in length. And then there is still stage 4, there is still further growth of the testis and the scrotum and increase the size of the penis, especially the breast. And then stage 5, the genitalia are in adult shape and size. That's for extragenitalia. So in the middle, another one, next slide, we take a look at their pubic hair as well. So when the patient comes to us, we take a look at the tenure stages. So stage 2, there's sparse growth of long, slightly pigmented downy hair. And then stage 3, the hair is considerably darker, coarser, and more curly. And then stage 4 is on adult type, covered the small area. And then the fifth one, the hair is in adult quantity and type with extension up until the thigh. Okay. Next slide. So in short, stages of puberty, this is from sunflower, we carry after this. So secondly, this is the differences between male and female. Facial hair in the male, voice changes are the arm for both of the sexes, gender, and the breast growth in the female, hip growth in the females with pubic hair development in both of the gender. So this is the table I get for the differences. We can read it after this. And next slide. In summary, okay, so this is the summary of what happened during puberty. So you can take a look one by one after this from estrogen, what does it happen, what does ACTH do, LH and FSH. Yep. This is for my part. So far, is there any questions for puberty?
Any questions not? Go ahead, then we can just continue. The important thing that you need to remember is the positive feedback and the negative feedback, okay? This one later on when you want to decide what's the causes for precocious puberty and delayed puberty, you need to go back to the picture where there's a negative feedback and a positive feedback.
Okay, so I proceed with the second part of presentation. My name is Nur Aina Binti Maksudeh. So my part is about the delay puberty. Just okay. So for definition, definition of delay puberty, it is the absence of or incomplete development of secondary sexual characteristic by an age 2 to 3 standard deviation above the mean age of onset of puberty. So cut off in Malaysia, lack of breast development by age 13 years in girls and lack of testicular enlargement by age 14 years in boys. Okay. So for stall puberty, different with the delay puberty, stall puberty is actually the puberty, it have initial development of puberty, but it disappear and not completed within the approximately 4 years of its onset. So the epidemiology of the delay puberty, it occurs in approximately 5% of apparently healthy individuals, and it more common in males compared to the females. And most common cause of delay puberty is the constitutional delay in growth and puberty, CDGP, which is about 53% of all the causes of the delay puberty. So we can classify delay puberty into 3. Okay, the first one is the constitutional delay in growth and puberty, CDGP, hypogonadotropic hypogonadism, or other name is primary hypogonadism, or the third one is the hypogonadotropic hypogonadism, which is known also as secondary hypogonadism. So I will explain one by one. For the constitutional delay in growth and puberty, CDGP, as I mentioned before, it is the most common cause of delay puberty, and it's more common happen in male 62% compared to female, which only 30%. Okay, because the delay onset will cause the delay in puberty and bone development. And we can see from the history that they actually have familiar pattern of inheritance, in which from the history we can get that there is history of late blooming running in the family. Okay, actually what happened in CDGP is actually due to transient or functional defect in production of GnRH from the hypothalamus. Transient, meaning that there will be transient low production of GnRH leading to low production of sex hormone. And eventually it will resolve by the time. Okay, so what makes differ with primary hypogonadism and secondary hypogonadism? We need to differentiate between these two things. For primary hypogonadism, or known as hypergonadotropic hypogonadism, as the name it suggests, primary hypogonadism. So the problem actually occur at the gonad. In the man, it occurred at testis. In the womb, in the girl, it occurred at the ovary. So because the problem happened at the gonad, so it will lead to the low production of the sex hormone. Okay, and because of the low production of sex hormone, it will have a negative feedback mechanism to the center. So hypothalamus, which is normal, we try to increase in production of GnRH. So increase GnRH will increase in LH and FSH. However, due to the abnormality or problem in the gonad, so the sex hormone remain low. As compared to the secondary hypogonadism or hypogonadotropic hypogonadism, so the problem occur at the hypothalamus or at the pituitary, because the problem arises from the center. So there will be low GnRH and low LH and FSH. Because of low of the stimulate GnRH hormone and LH FSH, it will lead to reduce in sex hormone. So in summary, basically the primary hypogonadism, the problem occur at the gonad, and secondary hypogonadism, the problem occur at the center. Okay, so we go in detail about the hypogonadotropic hypogonadism. Okay, actually for hypogonadotropic hypogonadism, among the causes are chromosomal abnormalities such as Klinefelter syndrome, Turner syndrome. Others are steroid hormone enzyme deficiency or acquired gonadal damage, such as due to post-surgery, chemotherapy, radiotherapy, trauma, torsion of the testis, or due to autoimmune disorder that lead to the gonadal damage. Okay. So anyone can guess what is this syndrome?
Okay, before you guess, can somebody just say what's the abnormal things that you see?
Can anyone?
Can I try?
Gynecomastia, okay. Others?
Abnormal height.
Okay, abnormal height, okay.
Absence of axillary hair.
Axillary hair. Lagi?
Larger jaw.
Larger jaw, no.
I don't think the larger jaw is what they're trying to show, isn't it?
I know. This is actually loss of the facial hair. Okay, so can you guess what is this syndrome? Arif?
Is it Turner syndrome?
No. This is Klinefelter syndrome, because we can see that. So I will explain later. So this is, thank you Arif. So this is Klinefelter syndrome. It's the most common cause of testicular failure.
Klinefelter.
Huh?
Klinefelter pronunciation. Klinefelter.
Oh, Klinefelter.
Klinefelter.
Klinefelter. Okay, thank you, Doctor. It's the most common cause of testicular failure. It happened in 1 in 500 to 1,000 males, about 0.1 to 0.2%. Okay, the problem is due to the seminiferous tubal dysgenesis. Okay, because of this dysgenesis, it caused the infertility. The karyotype for this is 47's XXY chromosome, but variant with more X chromosome are possible. So we look for the features that had mentioned by Arif and Sabri just now. Actually, for the Klinefelter syndrome, we can see that they has tall stature, not short stature, tall stature, and then tall stature, and then there will be highly. We can see that there is slightly feminized physique, and then there is frontal baldness absence, poor bed growth, and then tendency to lose chest hair. There is no chest hair, and breast development in 30% of the cases, osteoporosis, and there will be female type of pubic hair. Okay, this male, but there is female type of pubic hair pattern and small testes. So these features highly suggest of Klinefelter syndrome. Okay, so
First thing, jap. If you go back to the other slide, Dr. Changi, go back to the other slide. Now, the first thing you do is you decide first, is this person a guy or a girl, right? So if it's a guy, then you basically think of it as this is feminization of a male, right? So if you think of it that way, then one of the possible causes will be Klinefelter syndrome. Bukan gambar ini, gambar dengan sekali dengan yang tu. Dengan apa? Gambar yang sekali dengan gambar betul tu. So basically, you look at it, you first thing that you think of is whether this is a guy or a girl, right? So this guy is a male body, right? The presumption that it's a male body. So now looks like there's breast tissue, right? Guys supposedly would be more hairy. So there's loss of axillary hair, there is loss of facial hair, there is also the development of a bit of looks like breast tissue like a. So this would be a feminized male. So when you think of it that way, along the list of causes for a feminized male would be a Klinefelter syndrome, right? So you think of it in that way, it's slightly easier. Okay, Sambung.
okay, thank you, doctor. Okay, so this is good. Anyone can try to find the anomaly features. Can anyone? Okay, but Hakim,
So,
can
this
okay.
seems like a girl.
Okay.
Okay, so a girl. So she has a like a widely spaced nipple there, and also
Yes.
webbing of the neck.
Yes.
And this girl also appears short, has short stature. Yeah, I think this is most probably to be a Turner syndrome.
Okay, thank you, Chicken. That's correct because this is a girl. So among the syndrome that happen is Turner syndrome, right? And the features very high, suggest of Turner syndrome. So for Turner syndrome, a common cause it is the common cause of ovarian failure and short stature in a girl. 1 in 2,000 to 3,000 birth. Okay, the problem it have a syndrome of gonadal dysgenesis, and because of that, ovaries consist of small amount of connective tissue and no follicle or only a few atretic follicle, causing it incapable of producing sex hormone. Okay, so as I mentioned before by Shikin, among the features of Turner syndrome, it have low posterior hairline and has a webbing necks, as broad chest and widely spaced nipple, cubitus valgus, and actually we can the patient might have Caucasian of
Valgus meaning a wide carrying angle, meaning valgus meaning away from the body, right? You learned that in your auto, right? So there's valgus and varus. So it's varus. You remember that varus, VARUS, right? Arrows, right? ARROW, right? So pointing towards, right? So it's valgus, that means pointing away. So cubitus valgus meaning there's a wide carrying angle, that means the elbows are pointed away from the body in an anatomical position. Going back to the Klinefelter just now, so somebody said Turner's for the Klinefelter just now, right? So if you've already decided that it's a guy, with feminized features, it obviously cannot be Turner syndrome because Turner syndrome affect females, right? The person who said Turner's for this just now, right? Because you've already decided that this is a feminized male, so it cannot be Turner, so it becomes fetal. This one is a girl, obviously a girl, isn't it? Looks like it's a girl because generally gender norms would tell you somebody with long hair like this tend to be a girl, isn't it? And this person looks hairless, isn't it? Right? So this seems to be a girl. But then with the other features of the white neck with the white carrying angle, short stature, might possibly be Turner's. Okay.
Okay.
Next.
Thank you, Doctor.
Sambung.
Okay. So we proceed for the hypogonadotropic hypogonadism. Okay. Among the causes of hypogonadotropic hypogonadism is it can cause due to systemic disease such as cystic fibrosis, severe asthma, chronic disease, or organ failure, anorexia nervosa, starvation, excess physical training. Other causes are due to hypothalamic pituitary disorders such as pituitary dysfunction, isolated gonadotropin or growth hormone deficiency, intracranial tumor, including craniopharyngioma, and Kallmann syndrome. And hypogonadism actually can be due to acquired hypothyroidism. Okay. Okay. Can other person what is find the features of this? This is a man. Anyone?
Aina panggil nama satu-satu.
Okay.
Kalau Aina tanya macam tu memang tak ada orang jawab.
Hakimi? Hakimi?
Yes.
Can you find the abnormality in this man?
Based on what I can see is B is very long limbs, and also absence of hair on the chest. Then what else? Also,
Okay.
I can see that I think that's just it. I'm not really sure. Okay, sorry.
Yeah. So what can you suggest?
Maybe Kallmann syndrome.
Okay. Thank you, Kimi. That's correct. So this is features of Kallmann syndrome, and because we know that this is male. So, however, for Kallmann syndrome, it can occur in both male and female. Okay. In Kallmann syndrome, it's actually combination of isolated gonadotropin.
Aina, stop jap. I just want to see whether you guys pay attention. Now go back to that picture. Yeah, the picture before. If you just look at this, and I want to just see your powers, whether you guys are observant enough or not. If you look at this and nobody told you whether it's a guy or a girl, what's the clue that tells you that this is a guy? Let's see. Let's ask a guy. I think a guy would. Hakimi dah kan? No other guy. Zuzamil. Daniel.
Yes,
if you look at this picture, what would tell you that this is a guy if nobody told you this is a guy? What's the clue that this is a guy?
macam boxer je dia pakai.
Yelah, macam boxer je kan. These boxers have the opening, right? Only guy boxers have the opening there, isn't it? Isn't it? True or not?
Yes.
Yes.
Yeah, so that would tell you that this is most likely a guy, isn't it? Why would a girl wear the guy's boxers, right? So I just wanted to see whether you guys were observant enough or not. Huh? Okay. Continue your comments. What's the other thing you guys see? Is the breast tissue normal or not? You think the breast tissue is normal? May or may not be lah, but does the breast tissue look normal from here?
No,
does the chest area look normal? It doesn't
Normal.
quite look normal. Doesn't quite look normal. Looks like there's a bit of breast tissue, doesn't it? Right?
Yes.
Okay. Okay. Continue. Next.
Okay, so for Kallmann syndrome, it's as I mentioned before, it is combination of isolated gonadotropin deficiency with disorder of olfactory. Okay, so it's genetic heterogeneity. It is caused by mutation in the KM1 gene or KL2 gene or KL3 gene. Okay, the mutation causes a generalized neuron remain in primitive nasal area. Okay, so when we do an MRI, we can see that there is absence of olfactory bulbs and olfactory sulci. Okay, the symptom of finding that we can find because it can lead to disorder of hand, mirror movement. When one hand move like that, other hand will mirror the movement. And absence of the kidney dysgenesis, delay puberty, and hyposmia and anosmia due to a disorder in the olfactory. So this is the few. So for the futures, no. So for the futures, for in female, there will be no breath development. Okay, as compared to and then from history we can get the patient has primary amenorrhea and with no body hair. And for male, there will be no body hair and small phallus and testicles. Okay. So that's all regarding the causes. So we move to the history taking regarding the delay puberty. Okay. So in taking the history, we need to take the thorough history regarding the pubertal development. Either it's actually delay, absent, or stall. Okay. Because um, with the stall puberty, we might consider other diagnosis. And then we need to have we need to explore the associated symptom to suggest any syndrome such as for Turner syndrome, as I mentioned before, short stature, amenorrhea, Klinefelter syndrome, tall stature, loss of chest hair, Kallmann syndrome. Either there is alteration of sense of smell, anosmia or hyposmia, hand deformity, neurologic symptom. We need to find neurologic symptoms such as headache, visual disturbance, seizure, intellectual disability because neurologic symptom may suggest there is central nervous system disorder. And then try to find either the patient have symptom of hypothyroid, okay, and then the sense of smell for as mentioned before, for Kallmann syndrome. And then explore about the medical and surgical history. And then the patient have medical illness, congenital abnormalities, have surgery before, post-surgery, chemotherapy, radiotherapy, or trauma that indicate this patient have acquired congenital abnormality, acquired gonadal abnormality. And then we need to have family history. Regarding the family history, either there is family history of delayed puberty, because if there is history of running in family of delayed puberty, it might suggest to us that the patient might have CDGP, constitutional delay growth puberty, or family history of absent puberty or autoimmune disorder running in the family. And then lastly about the nutrition and excessive exercise, either the patient have a lack of nutrition, leading lack of nutrition that cause systemic causes leading to hypogonadotropy, hypogonadism, and exercise that lead to hypogonadotropy, hypogonadism. Okay, and next for physical examination. Okay, for physical examination, we need to evaluate. Okay, about the growth parameter, height, weight, BMI, and arm span, because we would like and also the secondary characteristic through the Tanner staging that I mentioned before by the first presenter Shahira, because early sign of sexual development we can notice from when we do this Tanner staging. Okay. And then system examination for features of dysmorphism and associated congenital abnormalities. Okay, as I mentioned before, we need to go thorough to the physical examination, try to find the symptom or signs of Klinefelter syndrome, Turner syndrome, and Kallmann syndrome, and other signs of chronic disease. Okay, so next is about the investigation. Okay, for the initial investigation, Okay, children with delayed puberty, should be evaluated for the possibility of the nutritional disorder, chronic inflammatory disease, or allergen nervosa. So we can send for full blood count, liver function test to look for AST, ALT, and also ESR. And then we do the endocrine test. Okay, for hormonal evaluation, we must include LH, FSH, estradiol, and testosterone because from send this test, we can distinguish between primary and secondary hypogonadism. As we know that primary hypogonadism, there will be increase in LH and FSH, while in secondary hypogonadism, there will be low LH and FSH. Okay, and then we can send for serum prolactin. Okay, why we want to send for serum prolactin? Because high in prolactinemia can suggest prolactinoma or any hypothalamic pituitary disorder. And then we can send for thyroid function test to rule out hypothyroidism as the causes of delayed puberty. And lastly, we send for insulin-like growth factor 1 because we would like to exclude possibility of growth hormone deficiency as a cause of delayed puberty. Okay, and next is the net investigation that can be done is bone age. So we send for radiograph of the left hand and wrist. Why we would like to do this? Because we would like to assess the skeletal maturation. And this bone age actually helpful for us for making decision for intervention. Example, in the case of CDGP, constitutional delay growth and puberty, we might consider to give hormone therapy. However, this bone age cannot distinguish between different type of delay puberty. Okay, and other tests that can be done depend on the situation, clinical presentation, is the karyotyping or pituitary imaging such as brain MRI. Brain MRI we can done if there is history. History suggests central nervous involvement such as headache, vomiting, seizure, or also laboratory findings such as hyperprolactinemia. So we need to do brain MRI. Okay, so settle with the investigation. So lastly is the treatment. Okay, for treatment of delayed puberty, it depends on the causes of the delayed puberty. If we have find the specific causes of the delayed puberty, so we need to treat the underlying causes. Okay, for example, if the delayed puberty is due to primary gonadal failure, such as the Turner syndrome or Klinefelter syndrome, so the treatment is by hormonal therapy. However, if the causes of delayed puberty is due to hypothyroidism, so we need to treat by giving the thyroid hormone thyroid hormone replacement. And lastly, if it is due to inflammatory bowel disease, so treat the disease. Okay. However, in majority of patients who have delayed puberty, they will have a low gonotropic hypogonadism. So without evidence of underlying disease. So okay, in the case of patient who have puberty delay, with secondary hypogonadism without evidence of underlying disease, for this group of patient, usually the most likely causes is either CDGP or isolated gonadotropin releasing hormone deficiency. Okay. However, to differentiate between CDGP and GnRH deficiency, it is often impossible during the initial evaluation. Okay, so in view of this diagnostic difficulty, the initial therapeutic that we can do if we presume CDGP is the first one, either reassurance, observation, or psychological support, or we might consider to give short-term hormonal therapy. Okay, example, we give testosterone for boy and estradiol for girl. Okay, so basically for the treatment is depend on the causes. Okay, so basically that's all from me. Any question?
I have a question.
My name is Nursalha. Regarding the bone age assessment, why they usually use the left hand only?
If I am not mistaken, because we want to standardize between the setting in worldwide. If we not have the standardized evaluation, macam satu setting buat kanan, one setting do the right and one setting do the left, so it will not how we like to differentiate, right? So the rule is we do the left hand, so it is standardized.
Good answer, yeah,
Okay,
for standardization. For standardization, right? You just imagine if every single country in the world have their own sets of X-rays to do bone age. It's good, very difficult to. It's difficult for you to decide based on different sets of pictures, isn't it? Right? So everything must be standardized. Okay. Yeah.
All right, thank you, Doctor.
Okay, if there is no other question, okay, proceed with next. Can Doctor?
Proceed.
Assalamualaikum and good evening. I read to Dr. Chan and Solifan. My name is Arfa Nadira and I will continue the presentation with topic of precocious puberty. So this is my outline of presentation. So, precocious puberty. Precocious puberty when there is secondary sexual development occurring before of 2 years in boys or 8 years old in girls. Okay, next. For the epidemiology, there is a registry-based Danish study using ICD-10 diagnosis estimated the prevalence of precocious puberty is at 0.2% for girls and less than 0.05% of boys. And at a UKM Medical Center, the statistic there stated that from 2002 to 2010, there were 53 patients diagnosed with precocious puberty. Okay, next. So precocious puberty, we can classify it into two based on its cause, which is GnRH dependent and also GnRH independent. And for GnRH dependent, it is also called as central precocious puberty. And it is due to premature activation of hypothalamic pituitary gonadal axis. And I will show the diagram after this. And this sequence of pubertal development in the central precocious puberty is usually normal and described as consonant, where it is different compared to the GnRH independent, where the sequence of pubertal development would be abnormal and described as dissonant, which is not sequential. And the cause of GnRH independent is due to excess sex steroids outside the pituitary gland, which is not related to the hypothalamic axis. Okay, next. And so this diagram shows the causes of precocious puberty as I mentioned earlier. So for the gonadotropin dependent, there is activation of hypothalamic pituitary gonadal axis, where this activation will cause increase in LH and FSH, which leads to production of more estrogen and also testosterone from the testes and also adrenal gland. And it is differ compared to if we see at the gonadotropin independent, where in a gonadotropin independent, there is suppression of FSH and also LH, and the excess sex steroid can cause the increase in estrogen and testosterone, which this cause can be from outside cause of the pituitary and hypothalamic, which can be either from the testes, adrenal, or ovaries cause. I will explain more after this. Okay, next. So for the gonadotropin dependent, we can look at the right box. So the first cause is the idiopathic gonadotropin dependent precocious puberty. It is the commonest cause of precocious puberty, where genetic and environmental factors are likely to contribute, and there may be a family history of precocious puberty. And in some rare cases, it can also be due to the central nervous system causes. For example, if there's any tumor involving the hypothalamus, any malformation of hypothalamus, any space occupying lesions, or acquired injury or infections. And genetic syndromes such as neurofibromatosis type 1 and Sturge-Weber and tuberous sclerosis can also associated with GDPP. Okay, next. For the gonadotropin independent, as I mentioned earlier, it is caused due to the gonadal or extra gonadal source. So for example, the cause can be the realizing tumors, for example, androgen producing ovarian or adrenal tumors, testicular Leydig cell tumors, or human chorionic gonadotropin producing tumors. And it can also be due to congenital adrenal hyperplasia and McCune-Albright syndrome. Okay, next. Next, Aina. Okay, so what are the clinical features that we can see in this patient? So firstly, in the females, so the ovaries are sensitive to the secretion of gonadotropin. So more cases are seen in girls that is related to gonadotropin dependent because of the ovaries are sensitive. So it is more common, and the presentation will be, as I mentioned earlier, is consonant, which is sequential, but perhaps rapid. And for the gonadotropin independent, presentation will be the growth of pubic and axillary hair, adult body odor, acne, and realization of genitalia can occur before the breast development. So as mentioned by presenter earlier, the normal development of the puberty, it should be breast development first, and then we can have the growth of the pubic hair and more. But in this independent, as it is not sequential, this realization can occur first before the breast development. Okay, next. For the clinical features in male, so the testis is insensitive to secretion of gonadotropin. So because of this, gonadotropin dependent is uncommon in male. However, if it is to occur, presentation will be bilateral enlargement of the testis with a testicular volume more than 4 milliliter. And for gonadotropin independent, we must rule out pathological cause. And the presentation can be unilateral enlarged testis if the patient have gonadal tumor or prepubertal testis. And we can suspect for adrenal pathology such as tumor or congenital adrenal hyperplasia. Okay, next. Okay, so this is just clinical features that I have mentioned earlier, divided into girls and boys. Okay, next. And this is diagram of the 10-year stage. And This has been explained by Shahira earlier. It's just the same. Okay, next. Okay, so how to approach this patient? Firstly, for the history. So we need to ask, when did the patient or the child first notice the changes? So it is important for us because, as I mentioned earlier, the definition is development of secondary sexual characteristic before the age of 8 or 9 years old. Okay, so and how rapid is the progression? So this important to know if it is rapid. Usually, it is more likely to result from a serious cause of gonadotropin independent precocious puberty, such as gonadotumors or cysts. Next. Okay, so we need to ask which sign of puberty. Sign of puberty can be any pubic hair, acceleration in height, acne, greasy hair, body odor, breast and genital development. And it's important for us to know the order of the sign because as I mentioned, the asynchronous order of the tender stage may suggest a pathological cause which is related to the gonadotropin independent precocious puberty. And have they noticed any other symptoms such as headache, polyuria or polydipsia or any impairment in vision? Because these symptoms could indicate serious underlying pathologies such as brain neoplasms. Okay, next. And at what age did the parents experience puberty? This is because the idiopathic precocious puberty is more common in girls of mothers who had early menarche, and sometimes inherited genetic associations are also common. And inquiry about family history is also pertinent if we consider any underlying disorder. And we also need to ask what are the child and parents' concern, because some children or parents may be concerned about serious underlying illness. In most cases, they can be reassurance that this is unlikely, and sometimes they also worry that menarche will commence long before peers, and adult height potential may be compromised. Okay, that is for the history. Okay, next. For the physical examination, we need to examine the height and weight and also plot it on the age appropriate growth chart. And if the height increase across one or more full center space, it can support the diagnosis of precocious puberty. And we also need to inspect for evidence of secondary sexual characteristic. However, this inspection can may cause understandable anxiety to the child. So we need to explain clearly about the rationale and why we do the examination and which parts of the body that we will examine. For example, external genitalia, the pubic hair, and also the breast. And for the picture at the right, so for the picture at the right, it is an orchidometer. It is a medical model that we use to get the estimation of the testicle volume that is measured in milliliter. So okay, next. So for the investigation, firstly, for the hormone and sex steroid level, we need to take a luteinizing hormone and also follicular stimulating hormone. And this is because this random level of LH can best screen for central precocious puberty, and both of these can be used to diagnose the precocious puberty after stimulating with the GnRH analog. And we also take serum estradiol and also testosterone because we want to see this level whether it is high or not. And for other blood tests, we also take serum adrenal steroid, which is a dihydroepiandrosterone sulfate, and we do thyroid function test if we suspect any hypothyroidism. This is because from what I read, long-standing hypothyroidism can also cause gonadotropin independent precocious puberty. And for the imaging, we can do brain MRI if we suspect for central precocious puberty, and we want to exclude any lesion or any injury to the central nervous system. And we do pelvic ultrasound to essential if we suspect for precocious puberty in girls, and because we want to evaluate the ovaries if there is any cysts or tumors. And we do ultrasound of the testes, and we do CT of abdomen, usually because we want to see the imaging of the adrenal gland. And sometimes we do radiographic assessment of skeletal maturation because we want to assess the bone age. Because in patients with precocious puberty, they can have advanced bone age compared to their chronological normal age. Okay, next. Okay, so this is the management. What is the aim? Because aim, firstly, we want to detect and treat any underlying pathology. We want to reduce the rate of skeletal maturation, which is assessed by bone age. And we want to address any psychological or behavioral difficulties associated with early progression through puberty. And we want to refer or discuss with specialists, especially if there are any concerning conditions such as we suspect any central nervous system lesion, and if we suspect any intracranial injury or any hypothalamic lesion. Okay, next. Okay, so firstly is conservative management. Conservative management is we will do it if there is no serious cause suspected, and we will do watchful waiting in order to determine the rapidity of development, and we follow up every 6 months. And for the gonadotropin dependent precocious puberty, we give a gonadotropin releasing hormone analog, and we follow up every 3 to 6 months to ensure that the progression of puberty has been arrested. For example, there is a reduction or there is no increase anymore in the size of breast. And we want to ensure that there is suppression of pituitary gonadotropin and slowing of development of secondary sexual characteristics. And for the gonadotropin independent precocious puberty, the treatment should be directed at blocking the production or response to the excess sex steroids. For example, if it is due to the tumor at the testes or adrenal gland or ovary, we need to do surgery. And if there is due to exposure to exogenous sex steroids, for example, contraceptive pills, we need to identify the source and we need to remove and stop. Okay, that's all from me. Any question?
Can I ask about the gonadotropin test? Can I know what results will indicate either it will be gonadotropin dependent or independent? Can you explain about the feedback mechanism?
Okay. So as I mentioned earlier, for the gonadotropin dependent, the LH and also FSH will be high, where the N or in gonadotropin independent, the LH and FSH will be low. So the results can determine the maybe doctor want to add.
Yeah, you need this picture, right? So it's gonadotropin dependent. Okay, you think of it this way. Just think of it in terms of English, right? So gonadotrophin dependent, meaning it's dependent on the gonadotrophin. That means gonadotrophin be high, right? So the LH, FSH will be high. Then everything down towards that, the estrogen or the testosterone will be high. Okay, then if you just think of it in terms of English first, gonadotropin independent. That means no matter what is happening, this is precocious puberty, right? Meaning your estrogen and your testosterone is too high. Okay, so if you just think of it in terms in the English language, so gonadotropin independent. That means regardless of the gonadotropin, yes. Oh, wait, wait, give me a second to settle my son's TDP. Okay, sorry about that. Everybody here? Okay.
Yes.
Okay, so if you think of it in terms of English, right? So if it's gonadotropin independent, meaning whatever happens with the gonadotropin hormones doesn't affect the estrogen and the testosterone. So the testosterone will be high anyway. So the testosterone and the estrogen will be high, but the LH and the FSH will be low, because that's your negative feedback loop, isn't it? Right? By right, it should be low, but then the estrogen and testosterone should be low somehow, but it's still high. So this is usually because of exogenous sources of the sex hormones, right? Understand now?
Yes, sir. Thank you.
All right. So if it's, I'm gonna take a look. If it's dependent, your LH and your FSH should be high. Everything else will be high. If it's gonadotropin independent, then your FSH and LH will be low, but your sex hormones will be high. Okay? Okay, then boleh sambung.
Okay, so we proceed to the last topic, which is on ambiguous genitalia. Assalamualaikum warahmatullahi wabarakatuh, and good evening to Dr. Chan and my fellow friends. And my name is Nadia, so I'll be presenting on ambiguous genitalia, or the newer term is disorder of sexual development, or in short, DSD. So this SD is defined as various congenital condition in which there is inconsistency between chromosome, gonadal, and or anatomical sex. So next, DSD is a neonatal emergency because the commonest cause of this DSD is congenital adrenal hyperplasia. So in congenital adrenal hyperplasia, the child might have adrenal crisis, which is there will be a hyponatremia, which will lead to hypovolemia, and patient may develop shock and subsequently death. So the major concern in the DSD patient are first underlying medical issue, which is the dehydration and salt loss, the adrenal crisis, urinary tract infection and bowel obstruction, because embryologically we know that urogenital tract and the gastrointestinal tract came from the same structure. So if there is a disorder in the development of the sexual or the urogenital, so there may be problem in the urinary and bowel. And the second concern is this decision on sex rearing. We want to assign appropriate sex to the and gender to the child to avoid wrong sex assignment and to prevent gender confusion. And the third concern is the psychosocial issues because we want to avoid any further gender identity disorder in the later childhood or adulthood of the child. So next is the normal sexual development. As we all know that fetal gonad is initially bipotential, which means it can be differentiated either to male or female. And the sex determining gene is the SRY gene, which is in the Y chromosome. So if the fetus has Y chromosome, so it will develop into male gonad, and if there is no Y chromosome, so it will proceed to the female gonad. Okay, so disorders of this chromosome itself or the gonad or the hormone itself, so it will lead to the disorder of the sexual development. Okay, so next we go to the classification. So the disorder of sexual development is divided into three, whether it is sex chromosome DSD or 46XY DSD or male DSD and 46XX DSD with female DSD. So for the sex chromosome, there will be either deletion or missing of the sex chromosome itself or addition of the sex chromosome. So the commonest cause is either Turner syndrome in male, virilized female, or Klinefelter syndrome. And the 46XY DSD we can further classify into disorder of testicular development itself, the gonad development, or disorder of the androgen synthesis and action, which is deficiency or inefficient androgen action. And the commonest cause in this 46XY DSD is the androgen insensitivity syndrome. And the last class is the 46XX DSD, which is further divided into disorder of ovarian development or fetal androgen excess, which means excess in the male hormone, so there will be less of the female hormone development. So I will be explaining further of the commonest cause of this classification. So the first is the sex chromosome DSD, which is the common is the Turner syndrome and Klinefelter syndrome. So next, so my friends earlier has elaborate extensively about this syndrome. So basically, in Turner syndrome, the child will be virilized female. So because of the insufficiency or deficiency of the female sex hormone, so there will be a disorder in the female sexual development in the female Turner syndrome patient. And for the Klinefelter, of course, because there is a deficiency in male sex hormone, so there will be abnormality in the sexual development in this patient. Okay, so next is the 46XX DSD, which is the female DSD, and the commonest cause is the congenital adrenal hyperplasia. So the congenital adrenal hyperplasia is among the commonest cause of this DSD regardless of the classification. Okay, so for the congenital adrenal hyperplasia, it is caused by variety of enzyme deficiency, but the commonest one is 21-hydroxylase deficiency. So other enzyme deficiency could be 11-beta-hydroxylase or 17-alpha-hydroxylase. And the classical form is either salt-losing or simple virilizing. Salt-losing is a severe form, and the simple virilizing, we just the female will be virilized. Okay. Next, okay, so this is the pathway of the production of the mineralocorticoid, glucocorticoid, and the sex hormone. So as you can see at the middle part of the picture, you see there is the progesterone one. There will be a block in the 21-hydroxylase. Yeah, there. So in this patient, so there will be a deficiency in the 21-hydroxylase. So as we all know that in any enzyme deficiency, all the substrate before the enzyme
will be accumulated, and all the product after the enzyme action will be depleted. So as you can see, in the mineralocorticoid at the lowermost, there will be aldosterone decrease in aldosterone level. So and in the glucocorticoid, so there will be a reduce of the cortisol level. And because of the accumulation of the 17 alpha hydroxyprogesterone here, so this substrate will be further converted into sex hormone. So this the patient will have increase in the elevation of the androgen hormone. Okay, so next. Okay, so the clinical presentation in neonate that in female infant, it will have virilized genitalia. It will range from either clitoromegaly or phallus-like structure, displacement of the vagina opening towards or into the urethra, posterior fusion of the labia, scrotalization of the skin of the labia majora, and variable pigmentation of area, and no palpable gonads. So for the pigmentation, because when there is enzyme deficiency in the cortisol synthesis, so there will be elevation in the adrenocorticotropic hormone, which is ACTH, and this ACTH that often cause the hyperpigmentation in patient. And no palpable gonad, of course, and this usually because it is female, so the gonad will be not palpable. And for the male infant, have apparently normal external genitalia with or without penile enlargement. So next. Okay, this is just a picture to show you the clitoromegaly. The second picture will show that there is a labial fusion, and the third picture is severe virilization of the female infant. And the lowermost picture, you can see that if you do not, we can easily mistaken that this genitalia is male, because if you can see at the middle picture, so there you see that there is a scrotalization of the labia. You will see that the labia look like a scrotum, so we easily miss that this is virilized. So we easily miss that it can be male. Okay, so next. Next is the PRADER scale, Rider scale, which will stage the degrees of the virilization of the female. Okay, so you can see the leftmost picture is the normal female, and the stage 5, we can see that it is like a male. So we easily mistook it for a male. Okay, so next. Okay, so how we approach the patient with congenital adrenal hyperplasia? First, for history, because it is autosomal recessive, so we can ask about consanguineous marriage in the family. The physical examination, we have first to palpate the gonad, whether it is absence or not. If there is presence, so it is less likely to be CAH. Okay, and then infant with suspected CAH, we should observe for symptom of salt loss, because the salt loss is adrenal crisis, so we have to treat immediately because it is a neonatal emergency. So the patient would have poor feeding, the child would have poor feeding, weight loss, failure to thrive, dehydration, and or hypotension. For the investigation, we do serial sodium and potassium for salt loss. So we will have we will see result of hyponatremia and hyperkalemia, because if you remember the diagram earlier, there will be a reduce in aldosterone. So you know that aldosterone will stimulate will cause absorption of the sodium. So if there is reduce in sodium, so if there is reduce in aldosterone, so there will be a reduce in sodium. So when there is reduce in sodium, as you know that water will follow sodium. So when there is reduce in sodium, so patient will have dehydration or hypovolemia. And you know that when sodium is absorbed, normally when sodium is absorbed, it will the kidney will excrete potassium. So if there is reduce in this, the vice versa will occur. So there will be hyponatremia and hyperkalemia. And then next, we do urea and creatinine to exclude renal disorder. So we want to differentiate whether it is either congenital disorder or just a renal disorder. And then we do test 17-hydroxyprogesterone, where if you see the diagram, that it will be increased, and also serum cortisol, early morning serum cortisol will be decreased. So for the management is steroid therapy to replace the glucocorticoid. To replace the adrenocortisone and to suppress the adrenal androgen. So we give oral just too small font. Oral hydrocortisone 3 divided dose in the range of 11 to 50 milligram per meter squared per day. So and for patient with salt losing, which is for patient with salt losing, so we give mineralocorticoid and also sodium chloride supplement. So next. So that's for the male DST of 46XX DST. So we move to the third classification, the last classification, which is 46XY DST. And the commonest disorder in this classification is androgen insensitivity syndrome. So okay, next. Okay, so AIS, androgen insensitivity syndrome, as the name goes, there will be a mutation in androgen receptor. So the receptor will be insensitive to the androgen. So as we know that if there is the insensitive, so there will be no production of the sexual hormone. So there is two types, either complete or partial. So if complete, this XY child will have complete external female genitalia, but genetically he is male, but phenotypically it is we can see female genitalia, or it can be partial. Patient can be partial where he has incomplete external male genitalia or ambiguous genitalia. So next. So this picture just show the range of the severity, either partial androgen insensitivity syndrome or complete up to stage 7, which is complete androgen insensitivity syndrome. Okay. And then the treatment for this patient is hormone therapy. So if so we give testosterone for this patient. Okay, so next this we have complete over the classification and the common disorders. So we proceed to diagnostic approach on this the ambiguous genitalia patient. So for the history, of course, as I said, you have to remember that the commonest cause, and it is a neonatal emergency, we must exclude the congenital adrenal hyperplasia. So in history, you have to ask about parental consanguinity and the obstetric history with the previous abortion, stillbirth, neonatal death, because patients who have this congenital abnormality often have this kind of history. And then antenatal history, where the patient have exogenous androgen or any endocrine disturbance that can further cause problem in the development of the sexual function. Okay, and then family history of unexplained neonatal death in sibling and close relative, infertility or genital anomalies in the family, abnormal
Is it just me or is the connection not stable?
I think her connection is not stable.
The presenter.
The presenter's connection not stable, right?
Yes.
Okay. Nadia? Oh, Nadia. Nadia? Nadia? Nadia, stop sekejap. What, May?
Hello, sorry, because here it's raining, so I think is it clear now? Hello.
Better.
Yes, now it is clear.
Yes, we can
Okay,
ask.
okay. Okay, sorry. So you want me to recap back the history again? Sorry. Around where did you guys stop me?
Recap back.
Recap back. Okay. So for the history, is it clear now?
Yes.
Okay.
Yes.
Okay. Uh, so for the
Nadia.
Dah tak okey balik.
Yes.
Hello? Hello?
Okay, sekarang dengar.
Yes, saya dengar.
Tapi typist ni tak dengar.
Nadia? Nadia, maybe just wait for a few minutes for a while before you sambung. No video, is it? Memang join back dah. Join back dah. So, correct. Memang join back dah. Nadia? Nadia, stop sekejap, Nadia. Nadia, oh Nadia. Nadia, stop sekejap.
I think she can't hear us, Doctor.
Oh, okay.
Now boleh pula. Nadia, it's your Wi-Fi or what? Maybe you leave and rejoin again and see what happens. May you join here, May? Got video or no video? Oh, really? Okay.
Okay, hello? Okay. Is it clear now?
Yes.
Okay. So so we proceed. Okay, for the history, because congenital adrenal hyperplasia is a neonatal emergency, and it is the commonest cause in patient in all neonates with this DST, so we must exclude this first. And because CAH is autosomal recessive, so we have to ask for the consanguineous marriage of the parent, and ask for the obstetric history of the mother, whether he has previous abortion, stillbirth, or neonatal death, because congenital problem often cause this kind of obstetric history. And for the antenatal, ask mother about any drugs taken, exogenous androgen or endocrine disturbance that this will lead to the disorder in the sexual hormone. And for the family history, ask for the unexplained neonatal death in siblings and close relatives, because it is congenital, so it can be due to the genetic problem. It is the genetic problem. Okay, and then as for the infertility, genital anomalies in the family, abnormal pubertal development, symptom of salt wasting during the neonatal period, which is the poor feeding, failure to thrive, weight loss, dehydration, and also increased skin pigmentation. As we all know that in this patient, there will be reduced in cortisol, which will lead to increase in the ACTH, and this ACTH will stimulate the melanocyte to increase the skin pigmentation. And then progressive virilization of the female. Okay, so next, for the physical examination, of course, the sign is hypotension because of the reduced aldosterone lead to hyponatremia, lead to hypovolemia, so patient will have hypotension. And hypovolemia will be manifested as dehydration, which is sunken fontanelle, dry skin, reduced skin turgor, and also hyperpigmentation in the patient. And dysmorphism, whether we want to rule out the Turner syndrome or any congenital abnormalities, and look for any cloacal anomaly as been shown in the picture on the right side. And then psychosocial behavior. This is applicable in all the children, whether this patient has gender dysphoria or any psychosocial problem to interact with other gender. And then appearance of the external genitalia, as we mentioned, the size of the phallus or erectile tissue, urethral opening, labial fusion, absence or presence of purple gonad, and absence or presence of the cervix. And then position and patency of the anus. Okay, so next is the criteria that may suggest DST, which is obvious genital ambiguity, apparent female genitalia enlarged clitoris, apparent male genitalia with undescended testes or micropenis, hypospadia or family history of DST, and also discordant between the genital appearance and the prenatal karyotype, which means the genetic it is male but the appearance is female, for example. Okay, so for the investigation, next. Okay, for the investigation, first do chromosome study because we want to rule out either it is due to the sex chromosome except with the deletion, which is in the Turner syndrome, or addition in the Klinefelter syndrome. And then abdominopelvic ultrasound to check for the reproductive organ, whether it is there is presence of uterus or ovaries, and genitogram. Also same, we want to look for the patency of the reproductive organ itself. And then exclude salt losing CAH, which is the serum sodium and potassium, 17 hydroxyprogesterone level or serum cortisol level, and serum electrolyte, of course the sodium and the potassium, and serum 17 hello? Hello? Sampai kat mana?
Ya, Nadia.
Sorry, it is raining. Oh my god. Jadi okey je. Sampai kat mana? Yang tak dengar?
I think at the serum electrolyte.
Okay, so serum electrolyte for the sodium and potassium, it will be hyponatremia or hyperkalemia in CAH patient. And so serum 17 hydroxyprogesterone increase elevated in CAH patient, and cortisol or renin reduced in CAH patient. And also we will of course check for the sexual hormone itself, which is the testosterone or LH, and FSH, and anti-mullerian hormone depending on indication and availability whether we want to yes. Okay, so next. Next. Okay. So next is the approach in the patient with DST. First, if we have we look at the patient ambiguous genitalia, so we have to do karyotype, as I mentioned, chromosomal study, whether it is the deletion of the X chromosome or addition of the X chromosome. Okay, and then palpate the gonads. If there is absence, so it is most likely to be female. So we screen for the CAH, as I mentioned, the serum 70 hydroxyprogesterone or 21 alpha hydroxy. hydroxylase deficiency. And if it's positive, so we do ultrasound scan and genitogram to check for the patency of the organ. Okay, and then if the corona is present, so it is most likely to be male, or if CH screen is negative, so we do endocrine profile to check for the sexual hormone, ultrasound scan and genitogram to check for the patency on the structure of the urogenital organ, and the gonadal expansion itself, and biopsy. We want to see whether if there is testicular tissue or gonadsism disorder. So if there is ovotestis, which means that there is presence of ovarian tissue and testicular tissue. So patient have ovotesticular DST. If there's this genetic testis, but it is partial gonadal dysgenesis. If the gonad is strict gonad, so the complete gonadal dysgenesis. And if there is a testis and no uterus, so we check for androgen, the hormone disorder, not for the gonadal disorder. Okay, next. It is also the same with the female 46XX DSD. So we check for the gonad itself. So if there is ovary or just ovotestis or strict, or and testis itself. And then okay, so the important thing is we have to screen or exclude first the CAH. Okay. So this is just diagrammatic how we want to approach the patient. So next is the management, the last part. So the goal is to preserve fertility in the patient and to ensure that patient would have normal sexual function later on. And we want to have patient to have phenotype and psychosocial outcome concordant with the assigned sex. So the general consideration, first admit patient to hospital because we fear of the congenital adrenal hyperplasia in adrenal crisis. So it is a life-threatening. So we must exclude this first. And it is urgent diagnosis and do not register the child until final decision is reached, and protect the privacy of parent and the child pending diagnosis, and counsel because in patient with DST, parent might be like scared or don't know what to do. So we have to counsel that it is biologically understandable, and we can correct this and encourage bonding with the parent and the child. Okay, so next is gender assignment. So gender assignment is not a simple decision. So there is many factors to be considered. The diagnosis, whether it is male or female, the fertility potential of the child, the adequacy of the genitalia itself for the function, and then the endocrine function of the gonads, and then parents' socio-cultural background, the expectation, acceptance, and then the psychosocial development, and also the decision about the sex rearing. So the gender assignment is a very complex topic. So we must have a thorough discussion with the parent and thorough investigation, so that later on it will not cause a problem to the child itself and also to the parents. Okay, next is gender reinforcement. So once we have allocate or assign the gender to the patient and to the child, so we have to give appropriate name accordingly to the child, appropriate upbringing and dressing, treatment of the underlying disease, CAH, and surgical correction if necessary by the surgeon specialized in genital surgery. So the table will show how what we could do for the assignment as a female to make the patient appear as male as possible or as female as possible. Okay, so next, this is the last slide. Okay, so the surgery. So if we want to do surgery, either it is a feminization surgery or masculinization surgery. So we want to do the genital appearance compatible with the gender, and obstruct the urinary emptying or incontinence, and so that patient will have good adult sexual and reproductive function. So the the emphasis is on the function, not on the cosmetic appearance. Oh, I forgot to mention that in patient we have CAH because it is neonatal emergency. So basically, patient would have a medical bracelet so that we can have we can give adequate treatment to the patient. So that's all from me for my slide. Is there any question? I'm so sorry for the technical issue.
Any questions, Nat? Yeah. Any questions? This is the important one will be the CAH. So make sure you look at the CAH. Make sure you look at the pathway for the sex hormones and how it connects with the steroid hormones also at the same time. You have that slide. Just now you shared the slide then. Which slide was it? Can you go back to the slide? Yang not this. Yeah. When you study that time, you guys need to look at this slide at the same time so that you don't get confused. Okay. Anything want to ask not? Ada apa nak tanya tak? Sorry, you noticed that I was out for about 5 minutes, I think. Something to do with the Wi-Fi. And also on the backup, right?
It's okay, doctor.
Anything not?
I think there is no.
Okay. Oh, you are at home or at the dorm?
There are two groups of us, some at home, some at the UIA.
But I thought you guys are doing face-to-face? No.
For the one who are at UIA can do face-to-face because due to PKP, some of us cannot return.
Okay, so whoever is already in UIA can do face-to-face, is it? Whoever like went home during that period when you guys could go home, now cannot go back to your UIA lah, basically.
Yes.
Okay. Very difficult lah, you guys. Okay. Any? What do I say? Are you the batch that got me in third year?
Yes.
So you've already heard me grumble about the seniors notes, right? About using the seniors notes, right? There's one UIA seniors notes that is like passed down, or you guys can buy. What's anyway? Don't use that lah. I know there's a pair of senior notes.
Okay.
Because the information is wrong. Books to read. This hour is enough. You guys know, right? Also, Essential Nelson's should be enough for medical students, right? Okay. On and off, you might need to refer to the big Nelsons, but otherwise, Essential is enough. If you read Essential, you just read Essential. If you're reading this hour, just read this hour. Don't give yourself more work by reading both books at the same time. Understand or not? All right?
Yeah.
Okay.
Development this hour is better than Essential Nelson, I think, but that's since you guys are at home, and I think there's a lot of copyrighted books. If you guys are at home, can for development. Sorry, I'm using the backup. I'm using the old phone as backup because I had to switch devices in between. So I don't think you can see. This is the Mary Sheridan from birth to 5 years. Okay, if you guys can just like get a copy online to read, then that's good enough lah. Don't need to buy because this is expensive. It's not worth the price. If you can get a copy from somewhere, borrow from the library or an ebook somewhere, then you can read this for development. Okay. If you've seen an online copy of this, you can just get it lah. Okay. You see an ebook of this, then this is not so bad. Okay, but this is for postgrad, but if you read like 1 page a day, so it's good enough already because it goes by diseases 1 page a day. I know you guys use the simple book, but this one will be better lah for physical examination. Okay. Otherwise, the other books I have here are postgrad, so probably not. What? Finish already? Sorry, finish class already. Yeah. My daughter is having classes. My son is having classes. I'm also having classes. The Wi-Fi is taking between. I finished. Okay, you have class with them then. Hello.
Hello.
Hi.
So I had to switch devices in between because the Wi-Fi became unstable. So books are those lah. I think that's about it. Anything you want to ask? Not anything about the posting?
Wait. I said I was cute only.
You're not cute. Come on. If you want to ask nothing ready, then we can just stop lah. Yeah.
Okay, Doctor. Thank you, Doctor.
Thank you,
Thank
Doctor.
you.
Thank you, Doctor.
Thank you, Doctor.
Say bye.
Thank you, Doctor.
Bye-bye. Bye-bye.
Bye.
Bye. Bye.
Bye.
Flashes into Wally.
Bye bye.